could affect this lecture. So find an easy caries risk tool combined with new visual aids will promise better understanding and for sure a better make. We must kick definitively the unseal of rigid cariology and create new paradigm with the support of clinical proof as sealing the dentin tissue remain very challenging. Hydrolytic degradation, upregulation of pathologic biofilm, cytotoxic effect leads to short service life compared to amalgam restoration, higher incidence of secondary caries, and higher oral health care cost. So time to think out of the box and create new field of discussion and new concept, but staying close to the real life dentistry. Please, with just 4 lines, please cover all the blue box. And we need to create new concept like the MITP concept, meaning minimally invasive treatment plan concept, and bioactive dental concept. The minimally invasive treatment plan concept is based on MI identify, prevent, restore, and recall, and combined with a new device for the caries detection, for the smart excavation when using photonic signal, and the new cavity preparation instrument. All this point will bring up-to-date treatment decision making for MI treatment. The 3 levels of treatment rank as non-invasive, micro-invasive, and invasive should integrate ion release biomaterial according to the individual caries risk, the caries activity, and clinical situation. And the first query is when to intervene and how. 3 keywords clarify this point: cavitation, carious activity, and cleansability. Very important. This suggests the use of specific tool for clinical application. Please refer to our publication below. And when using ion release biomaterial, and
Professor Harvey, I think the use screen is fixed, is freezed in the first slide. So you need to run your slideshow. Sorry for that.
I don't understand, sorry.
So your screen is fixed. So your slide, please run the slideshow.
What I have to do?
Yes, just run the slideshow. Please press F. So we have a fixed screen, a freeze screen, and the your first slide only.
I'm sorry.
Yeah. You just go and go for slideshow.
This one is okay now?
No.
No?
Yes. So, Professor, if you can see, this is your screen. Yeah. It just freezes. Yeah. Now I think we are in slide number 8. So, Professor Harvey? Okay, Professor? Yes, Professor. Now it's okay. So please unmute the sound, please. Yes, that's fine, man. That's fine.
And now it's okay?
Yes, it's fine. That's fine.
Okay, perfect. So sorry also for the technical problem. So let's go on. Yes, so what's news about the carry risk assessment, which is the first level which influence all the clinical procedure and decision to use iron release biomaterial or not. So carry risk assessment is then the first crucial step in the MITP concept for effective and personalized care on purpose. And to simplify this task, an application has been developed to desecrate and make the carry risk assessment step much easier for general practitioner. Yes, you can see you can retrieve it on the Play Store, and the name is MI Dentistry CRI. And so it's a reason that we can share it and then eventually make some mutual research about it. And so carry risk assessment is the DNA of the mini-invasive treatment plan and the trigger for ion release biomaterial use. Analysis of the protective factor, those relate to the patient and clinical finding, will evaluate in an exhaustive way the individual carry risk. This step control and influence all the other one, meaning that restorative procedure and ion release biomaterial are closely linked with this step. So let's speak about the cleaning step and caries detection. First, disclose with specific dye or use photonic signal. And part of the identification step, cleaning the tooth surface without damaging, is absolutely mandatory. Glycine, soft sodium bicarbonate, and erythritol powder are used on purpose as non-invasive treatment. Sodium bicarbonate silice oxide for invasive treatment or specific dentin conditioning. So depending on the powder shape and hardness, you can open or not the suspicious groove without injuring the residual tissue. Operative step is allowed when using bioglass and silice oxide powder, and between you can use soft bicarbonate or calcium phosphate powder. The point of agreement concerns the probe banning. No way to use the probe. Now teeth are clean. Caries risk assessment are evaluated in part. Caries detection can start. Thousands of publications claim about caries detection tool efficiency of the specificity with high value. However, they never inform about the positive predictive value and more or less about the clinical efficiency. So time to definitely eliminate device not allowing picture, magnification, and photonic signal. So we must look also at the diagnosis tool with an unconventional angle and choose new criteria like capacity to detect lesions cavitation, caries activity, and cleansability. Following these new criteria, most of the traditional diagnosis tools completely fail. The presence of surface cavitation is a starting point for non-micro-invasive and invasive restoration. Activity is a warning sign to reverse or to moderate the caries process, and cleansability is a moderating factor refer to our publication just made in the British Dental Journal. So finally, all these tools at least fit with one of the three main criteria I just described. Most of them have now photonic signal like photothermal radiometry for canary, infrared signal for diagnostic and fluorescence, in particular for the SoproLife camera, and also the Zoomax microscope, and the new loop from Design for Visions here, yes, are very useful. And note that diagnostic based in infrared signal is more devoted for proximal lesion diagnosis. So finally, the flow chart reveals itself. Visual aid with magnification and image will influence the HCDS score and improve the operative steps and recall control. Photonic signals are more appropriate for caries detection, caries activity, and help for caries excavation. Afraid of overtreatment risk, a lot of publications state that 2.0 magnification is optimized for caries diagnosis. Naked eye visual detection is the most commonly used method for lesions detections currently. For human teeth, the average occlusal fissure width range from 40 to 150 micrometers. Therefore, in daily practice, at an average distance of 40 centimeters, the clinician is able to distinguish 2 points separated by approximately 130 micrometers, suggesting that most surface of the pit and fissure are in fact non-detectable visually, even in the absence of biofilm and stain. So let's have a look of the fissure detail and information retrieved thanks to the combination of magnification and fluorescence. Fissure inside fissure were revealed. Let's see the picture in fluorescence, and then we increase the magnification. And then after cleaning, you can see that there is inside the groove some other point of entry. And at the end, when we use the SoproLife camera, the SoproLife camera, you can see that inside the first groove, you have nearly 6 points of entry of caries. That's always the same with this high level of magnification. So to summarize, disclose, magnify, clean, and diagnose. In the biofilm, if the biofilm is soft, start to clean with erythritol, and if it's sticky, no way without using sodium bicarbonate. Peel powder or at least bioglass can help also. In detail, thanks to the fluorescent signal, you can see active biofilm looking red in the deepest part or in the surface of the different groove. So after cleaning, time to decide to open or not the fissure and decide which haddock biomaterial to be used: resin, mineral enriched composite, glass ionomer cement, high viscosity glass ionomer cement, and also doped adhesive system. The question about ion release biomaterial deserves to be asked, and restrain them seems illogical. So concerning the photonic signal, naturally, light photon can propagate through the crystalline enamel and dentin tubule. Demineralization causes change in the ultrastructure of enamel and dentin, and a consequence is a change in the optical signal due to the modified light interaction and accumulation of ages for advances glycosylation end product, in brief, the Maillard reaction. In yellow highlight, the device described and the specific wavelength. So among the photonic tools for diagnosis, some allow video and magnification, and others just give numerous cutoff value or not after the light excitation. That's the point. So for example, one of the main failure reasons for diagnoden or pain based on laser signal is that the crystal fiber tips is too large, and in case of non-cavitated lesions, the device is unable to detect cavitation. And the laser signal is highly disturbed by the fluorescence coming from debris in the deepest part of the groove, meaning that in this clinical situation, drilling is unnecessarily recommended by this tool. False positive signal remain also the main drawback as for phase tool on the right side. Caries scan based on electric signal in particular has disappeared from the dental market despite few papers in very prestigious review and renowned author. So note that this tool claims to have very high level of sensitivity and specificity, but in fact, they nearly fail facing all the clinical items: cavitation, caries activity, and accessibility. And more, there is no way to retrieve picture and video with these two tools. So visual aids limited to magnification just enhance the visual diagnosis and high resolution power. Except the one with fluorescent signal, there is no way to record picture and video with loop, classical loop. So classical loop are the first recommended steps and the cheapest tool. Everybody knows it. Then note that this new generation of loop allow adaptable magnification from 3.6 to 6.4 without changing the glass. Note that at 6.4 fold, we are close to the microscope powder, and detail obtained with this new loop are really remarkable. And also at the end, this new loop from real dental vision combine 2.8 magnification with a photonic fluorescence signal. Active biofilm and caries activity can be diagnosed more easily on the fluorescence, and hence, all the technique is based on the fluorescence and diagnosis concept from Professor Liviu Steyer. So new generation of microscope combine high level of magnification, photonic fluorescence signal, and high definition picture and video. And the range of magnification goes from 3.1 to more than 30-fold magnification. So precision, high magnification open new horizon and more reduced muscular fatigue due to a better working position. So you can see a lower molar, and then we can combine all the technique, meaning airflow device, very tiny burrs, and then all the step is perfectly controlled thanks to the view and the high level of magnification. And with also specific microscope Zoomax 1, we can also use fluorescence to control all the excavation step. You can see all the detail when we try to rebuild this occlusal surface. And now we feel very more secure thanks to the help of fluorescence photonic signal to keep the outborder clean according to the peripheral seal concept and preserve the lead dentin. That can be done with a fluorescence microscope or fluorescence camera. You can see that at the edge of the cavity, we can specifically excavate the infected tissue, and then thanks to the peripheral seal concept, perfectly preserved the pulpal wall and made the rebuilding step and restorative step in very nice condition. And combination of 3D Epson glasses, iPhone or Android are now possible, and the 3D picture capture by Bluetooth connection are now available and completely change the game. Now, sometime when I work with my young student, you can see they just wear the Epson 3D glass, and then they can follow in the same time what we do on the patient, and then it's a very nice level of pedagogic approach. But loupe and microscope are still dependent on the quality of the mirror used, reflection factor and brightness avoid picture superposition and increase quality of the different clinical detail. You have the name of Proudhon and so on. And also, when we use microscope, a new generation of blowing mirror allow to work in indirect position almost comfortably. You can see here we are the second upper molar, and then directly we can see with a microscope, and then the blowing mirror give all the opportunity to work directly and control all the different steps. So the main drawback of loupe is that there is no way to record picture and video, and note that the new generation of microscope open now the field of the fluorescence photonic signal. So let's see now the trans-illumination concept in detail. JagnoCam used a near-infrared trans-illumination to illuminate the teeth and capture real-time image. Longer wavelength reduce light scattering and the beam penetrate further into the tooth. The reliability of this technique has been widely documented and found to be effective for early carious lesions detection, especially in a proximal surface. And the new generation, which will be launched by the end of the years, combine infrared transillumination and also the fluorescent signal. All these photonic signal will be mixed in the same tool. We will have the opportunity to test it in a few days. But JagnoCam transillumination for the practitioner, they should correlate the given JagnoCam caries level with the percentage risk of cavitation, and the treatment is based using the JagnoCam classification of finding. That's the point. JagnoCam transillumination at this time failed to assess the caries activity, the caries diagnosis, and the cleansability, and doesn't help in operative step. However, it helps to reduce the X-ray radiation exposition and give nice information on the proximal lesion's caries volume and position. Concerning the Canary system, which is based on photothermal radiometry, combining laser and picture in detail, what can be done? What can be said? Yes, the Canary system is a pulse laser-based system that uses a camera and a combination of heat and light detection and quantification putatively examines the crystal structure of teeth and mapping carious lesions. But has the JagnoPen, VistaCam, and Canary give clinical scale, and we personally think that cutoff values are not useful for clinical diagnosis at that time. Yes. What happened if the system give you a level value of caries around 50? Is it decay? Is it healthy? Is it the beginning of advanced decay? It's not very easy to use. So nice device with a lot of possibility for the canary system, but fail concerning also the caries activity, the perioperative aid, and one drawback is that this device is not yet sold in Europe. So concerning the SoproLife and SoproCare camera, these tools reveal what we have called H for Advanced Glycated Hand Product from Maya reaction, and the clinical application of the image are based on what we call the live DT concept for light-induced fluorescence evaluator for diagnosis and treatment. So we have 5 points in this concept. We have no time to detail all these points, but that will be done during the different video we will share all together. So let's see in detail the information given by this kind of tools. So you have the first magnification, then we increase the magnification, and also you can share this image with your patients, as you can put this image on a large screen, and then you can see here we have detail of the point of entry of the caries in the center, and we also have information about the fissure, and then we can use the fluorescence mode to better understand if we have a caries activity inside the groove, and so on. So huge information and then easy to share point. In that clinical situation, sticky debris fulfill the fissure. How to remove it without injuring surrounding sound tissue? Remember, non-invasive or micro-invasive will depend on the powder hardness used with the hair flow device. And hair polishing and huge magnification are combined. Sealing can be performed using resin sealant. Here you have detail given by the different tool. And this strategy is highly efficacious for arresting non-cavitated lesions and might also be suitable for managing minimally cavitated lesions in non-loaded area. You can see in detail information given. Here we are. And also, in case of active caries, fluorescence variation due to the collagen fiber modify and guide our excavation procedure. Layer after layer, the red signal is softly removed or partially left, depend of the caries activity powder. And the result at the end, before applying glass ionomer cement on the vestibular side of the second upper molar, you can see we have no more red signal. But in case of less active caries, red shadow can be preserved, which match with the lasery caries layer. And the endpoint of the dentinal dentin tissue excavation is now recommended to be what they call leathery dentin or firm dentin on the pulpal wall, and fluorescence can assist reunification of tissue to be removed, limiting tissue damage. And cleaning the margin of the cavity, preparation continue to remain a challenge. Fluorescence helps to control it due to the reduction of the red signal and increase of the green signal after the excavation. But you can see around tenfold is still needed. That's a problem. And thanks to the high level of magnification, we can have detail of the leathery dentin structure and also to better understand the peripheral seal concept. Here we are in perioperative step combining magnification and fluorescence give huge information about the caries activity. You can see on the left side, it's the daylight mode and then the fluorescence mode on the right side. And then we increase the level, you can see the different fissure, you can see the infected tissue and so on. And then also huge detail of caries spreading on the proximal side and also facing the white spot. You can see that the first modification of the dentine reaction. So let's see this very short video to see that before trying to work, we absolutely need to better understand and control the biofilm. All the dysbiose need to be removed. As soon as we have removed the biofilm, you can see the point of entry of the caries. As it was a very high caries risk patient, we decided to only use high viscosity glass ionomer, and then we sorry, and also we use specific hand excavator, and we also can mix the use of specific papain gel, meaning enzyme excavation help. And you can see also we can have a lot of detail of the cleaning of the cavity thanks to the fluorescence, and you can see the border looking green, meaning that everything is perfectly clean. And then at the end, we inject a high viscosity glass ionomer, and then we control all the spreading, the overflow of the biomaterial, and then at the end, we have just applied a high viscosity glass ionomer. And then we covered all the tooth with also fluoride varnish. So ProLife and care match with all the new clinical criteria, except for proximal lesions where teeth need to be separate with plastic wedge, ivory separator tools, or orthodontic separator. And remain few other devices like Q-Raycam, Vistacam, and Calcivis concept supposed to reveal the caries activity. We have no time to get in detail with all different tools, but refer to our last publication made in the British Dental Journal, Carious Lesions Detections Technology, Factual Clinical Approaches. That will summarize all my points and given there. So now, time. Sorry. So concerning now the iron release biomaterial, thousands of publications can be found, but available products on the market are quite reduced and can be ranked as glass ionomer, resin modified glass ionomer, new group called mineral enriched resin composite like Activa, with methacrylate functionalized calcium phosphate, modified adhesive system group, and calcium silicate material family, and more all the conditioning technique aiming to stabilize the hybrid layer and dentine interface. And remember that conventional composites have no bioactive effect, no buffering capacity, and with high susceptibility to secondary caries. And so you can please read our last publication made in Material, commercially available ion release dental material and uncavitated lesions, clinical treatment option. And we did it with a very renowned author like Banerjee, Salvatore Soro, and so on. So enjoy to read this new publication. And also the huge complexity of enamel dentine must encourage us to remain very humble about composite sealing capacity. The Raman spectroscopy cross-section profile clearly show a novel organic protein containing enamel matrix layer with tough and spindle structure which could interfere with a perfect seal. You can see in detail here all the very complex shape of the enamel dentin junction. So be aware to be very humble when you realize restorative dentistry. And more, Tassery team also focused on the influence of the assembled supramolecular structure. Also, it's very complex, and be aware that it's not so easy to seal all this collagen dentin surface. So, go back to the clinical situation. The first flow chart from occlusal score 1, 2, 3, and 4. In case of high caries risk and active caries, just use ion release biomaterial, meaning glass ionomer and so on. And in case of non-active caries, the only remaining parameter is the possibility to set or not the dental dam. Close to score 3 and 4, the caries cavity could be suggested if useful. In the MI Prevent square, even for deep caries, non-invasive treatment like silver diamine fluoride must be promoted mainly for high caries risk, disabled patient, young patient with no compliance, and geriatric dentistry. Recommendation can be found easily in our MI handbook or various publications. Silver diamine fluoride application, which is a mix of atraumatic restorative treatment for active caries and non-invasive one. Clean the tooth with erythritol, hairspray, apply silver diamine fluoride, rinse and dry before covering the tooth with high viscosity glass ionomer. So micro-invasive treatment concern initial or moderate caries and sometimes deep one, as caries depths are really underestimated. And it should be applied differently depending on the caries and the caries activity. Micro-invasive mean hair polishing with harder powder, and that we done in case of wisdom tooth. We perfectly clean the occlusal surface. You can see all detail given by the high level of magnification. And then we decided not to drill this area, but just completely use what we call the press finger technique and completely seal all this area using ion release biomaterial. And then we have time to set again all this area and to analyze again what happened concerning the caries risk for this patient. You can see both wisdom tooth on this patient are completely sealed, and then we have time to treat all the other tooth. And the second flow chart concerning the proximal area, even you use orthodontic separator, lack of accessibility and difficulty to diagnose cavitation are constant. The word when to intervene are full of doubt. In this clinical situation, when facing high caries risk patient, we remain often ineffective. Resin infiltrant like icon, which is a non-bioactive resin, seems a promising technique, but silver diamine fluoride show now very high level of evidence. So let's see all together how we use silver diamine fluoride. So in the proximal area, I hope that you can see the video. You can have a look. We disclose the biofilm using the color dye, plaque dye, and then we gently clean all the surface before using silver diamine fluoride. And then we use a ivory separator to separate, and then we clean again remove the residual biofilm in the deeper side. And then you can see, thanks to the high level of magnification, you can see that the different starting point of caries using infrared, using fluorescence, and then we have a lot of information, meaning that we better know if the caries are on the vestibular side, palatal side, and then we start with the first solution. It's RIVA Star Aqua from SDI, and then we gently applied. We can use interdontal brush, and we completely embed all the surface with silver diamine, and then we use iodure solution of potassium iodure to reduce the staining given by the first solution. And then we have completely protect this area, this first step of occlusal of proximal caries. And also for proximal lesions, always first disclose, then clean the tooth with erythritol and decide it carefully the ad hoc treatment. You have the choice between icon infiltration, cure-dent, sealing patch, or even use silver diamine fluoride. Here's a video. You can see we use specific matrix, and then we use specific acid conditioning, chlorhydric acid, and then we dry completely the area, and we infiltrate the surface with resin infiltration solution that will perfectly protect all this area. So have no solution between, I don't know which is the best technique now, but certainly silver diamine fluoride is the most interesting technique for the future. So let's go ahead. So why we should promote the combination of magnification photonic signal to diagnose cavitation. You can see on the left side, in daylight, we saw the brown dentin through the enamel layer. Infrared in the middle give information of the caries volume, and bite-wing give very poor information at high level of magnification combined. Found the cavitation. Here we are. You can see on the purple arrow, we can see the cavitation. So we have to mix all the different techniques. So the main problem, do you have any idea to treat this caries without being iatrogenic? It's the main point. I have no solution. So the third flow chart, when cavitation or proximal lesions have occurred and lesion has progressed well into dentin, non or macro-invasive approaches do not seem to be good option, and invasive treatment should be employed. But as previous step, individual caries risk and caries activity leads our final treatment decisions making. If it's low caries risk, slot or tunnel preparation combined with ion release biomaterial could be performed as first approaches. And be aware that micro preparation cannot be done without this tool like sonic or ultrasonic diamond insert with half round, round, or class 2 shape. And some are have very specific shape to allow a very complex caries point of entry. And remember that these tools are not devoted for caries excavation. So let's see the video. All together, you have a very short, small caries in this proximal area. We have to disclose and see the amount of biofilm, and so we combine a fluorescent dye, fluorescence signal, and you can see information given by the disclosing biofilm, now visible. And then we use very small burrs, and we put a protection between the in this interdental space. So as soon as we have made the first approach, we use specific insert, half round insert, and you can see, and then we will preserve the marginal crest and go inside, and then clean and find the point of entry of the caries. And as we have made the first cavity, we are allowed, we have the, we can take advantage to treat the second point of entry. We use ceramic burrs to gently remove the caries infected. We check the sealing of the matrix, metal matrix. You can clean the area with also phosphoric acid, and then time to inject the new kind of glass ionomer from GC, and you can see at the end we have perfectly protect the two marginal crest, and then we covered all the tooth with a specific fluoridated varnish to protect all these points. So it's very aesthetic approach, and we do not open the marginal crest, and we preserved, we highly preserved, greatly preserved the tooth. So concerning to make the point, my point clear, academic or standard concept advice to just clean the enamel dentin border, which is a unique common point with the bioactive dental concept. Do not recommend to apply dentin substitute, neither dentin disinfectant, and caries risk assessment doesn't really influence the biomaterial choice, and magnification is not promoted as a claim that could worsen over treatment. But bioactive dental concept, in contrast, is closely linked to the caries risk assessment, the caries activity, and the presence or not of bondable enamel in proximal area. Evaluate the caries risk assessment, disclose, clean without damaging, use photonic signal, magnify, selectively excavate, disinfect the dentin tissue, and applied ion release biomaterial are the key point. The only common point with the previous concept is to maintain the out border clean, also called seal peripheral concept. So the fourth flow chart, in the bioactive dental concept, the flow chart for invasive treatment follows the caries risk, the dentin caries activity, and the little proximal bondable enamel factor. In this three clinical situation, ion release biomaterial could be recommended as a unique restorative biomaterial weighting the caries rebalancing and has dentin substitute. If low caries risk or inactive caries, all techniques are allowed. And concerning the icon called specific conditioning, it's just a wing to all promising conditioning and disinfected technique like photoactivate disinfection, nanoglass powder spraying on denting, anti-MMPS conditioning, new doped adhesive, and papain dentin conditioning. Two factors have to be resolved: sealing capacity and ion exchange capability. And when the dentin is involved, it is now easier, thanks to the photonic signal coupled with magnification, to see the different caries layer, like the red caries dentin layer due to the Maillard reaction, and make the selective caries excavation easier. With fluorescence camera or microscope, we just follow the red signal. And fluorescence image help to differentiate the caries layer and choose the best excavations level. It's now recommended as smart caries removal concept to stop close to the lasery dentin or film dentin layer, depend on the caries deepness, but how to see this layer without visual aid and fluorescence, and be sure to keep the out border perfectly clean. Concerning the fluorescence signal, please read our publication. So we are close to the last slide. So let's see a different, more clinical situation with a fifth flow chart in case of extensive occlusal lesions. Clean the tooth and lesions to remove the biofilm debris without damaging them, and take account of the caries risk and also the dentin caries activity. Let's see in detail. So in case of very high caries patients, let's have a look at the tooth. So we use plaque disclose, and we use also fluorescence dye. So you can see information given by fluorescence when combined with fluorescence dyes with very active caries and also gingival inflammation. And so after cleaning, you can see the point of entry and the different caries score. It's a caries score around 5 and 6. I suggest 5 and 6. And all the different caries activity with the point of entry of the caries and so on, and the difference between the different color of the red signal. And so at the end, we have used a high viscosity glass ionomer to treat this area without any problem. So restorative treatment of occlusal caries remain easier due to the enamel peripheric border. The main factor is the caries activity, which is revealed the fluorescence photonic signal. With the fluorescence technology, you can see we just have to follow the red signal. If it's hard, leave it. If it's smooth and easy to remove, you can gently remove it and control with the fluorescence and the different level of magnification and fluorescence. And you can see at the end, it's perfectly clean. We have completely cleaned all the border of the cavity. We have left the red signal just because it's what we call the least redundant step. It's quite nearly hard, and we have combined the rebuilding of the tooth using resin modified glass ionomer and composite to rebuild the occlusal surface. And so the last flow chart. Remember, in case of proximal area, we have to face two clinical conditions, with or without a cervical enamel. When the bondable enamel border is preserved, you can face only two challenges, active or inactive caries. First, if inactive caries, all technique can be promoted. Dual composite, low flow, injected dual composite, bullfilk, or even warm composite with special heating dispenser. In the second situation, in case of active caries, enjoy using open sandwich technique with ion release biomaterial. And in case of high caries risk, just please do not use composite. Use glass ionomer cement, high viscosity glass ionomer cement, and new generation of mineral enriched composite. And now the marginal crest cannot be preserved, and one usual way to treat high caries risk patients, use a ceramic burst to selectively remove the soft dentin, finish the preparation with diamond insert, rebuild with high viscosity glass ionomer, and monitor. And please read the previous paper also from SEBNET in clinical oral investigation with very nice result at 6 follow-up. And also, among the mineral enriched composite with alkaline glass filler, we have the Santion product from Ivoclar, which is a very promising product, releasing of fluor, calcium, and hydroxyl ion could help to reduce demineralization, increase romanization, and also a very nice buffering effect is expected from depend of the buccal pH. And so with our cervical enamel, we face two challenges, caries activity and little bondable enamel. But in contrast to the first situation, we only recommend ion release biomaterial. And sealing capacity are really reduced in this clinical situation. Let's have a look. A PubMed research on this topic, the sealing capability with keyword glass ionomer and open sandwich technique give around 600 publication. And here we have made 3 publications with my friend Kubi Stefan, and you can see the result when we have no bondable enamel in a very large cavity. Even you use flow dual or chemo composite, the sealing capacity of the different products are very low. We've got a very better result with a resin modified glass ionomer and also calcium silicate product. And if we compare all this result when we use flow and low flow in a very condition with nearly 100% of humidity, you can see that the flow composite fail to give a very perfect sealing situation. So the second point concerns the ion.
Professor.
Yes.
We are running ahead of time. Can we have just one slide or one or 2 slides more?
Yes.
Yeah, please.
So we will give the last slide. Here we are. It's to give all the information given by the different point here. So before opening the tooth, you can use a stamp technique to have the shape of the different occlusal surface, and then we use a specific burrs, and then you can see that we will lost all the bondable enamel, and we use specific diamond insert here. And then we try to preserve the bondable enamel, and you can see that it's a very active caries. And so time to disinfect, to use a photoactivate disinfection, to gently remove all the infected tissue, to combine magnification, high level of magnification, and also fluorescence signal. You can see the different color between the infected tissue and the affected one. That will also confirm in daylight. And we use dental liquid dam to perfectly seal all this area. We inject the resin modified glass ionomer, and before you can also disinfect all the area using a photoactivate disinfection technique. And then we inject the resin modified glass ionomer. And so I would like to thank you again to your patient. So we have enough time to speak in detail of the different diagnosis and all the bioactive dental concept. And thanks again for this invitation, and take care, and hope to see you not in virtual but face to face.
Thank you, Professor. So thank you very much. And we would like to open now just for one question, because we are running out of time. So if you have a question, just feel free to tell it in Arabic. I will translate to Professor if you want. So just one more. So thank you very much. Professor, can you stop sharing the screen? We have something like a tradition. We will take a with your. So our VIP guest will take a memorial photo with your screen. Can you stop sharing your presentation, please?
I'm sorry, could you repeat?
Yes, can you stop sharing the screen? Can you stop sharing the screen, your presentation, please?
let me know.
Thank you very much. Thank you. We will take a photo with your screen. Thank you. Professor, we invite our VIP guests, please, to stay on the stage. Please come on the stage.
احمد انا عايز اشرح له احمد ليه بعد في نفس الوقت.
Thank you, Professor. Thank you. Thank you very much. We will share with you and also the reports. Thank you very much. Goodbye.